Good afternoon, everyone, and thank you for joining us. We'll get started in just a few minutes. Just a few things to note. This webinar is going to be recorded and all participants will be on mute throughout the program. We'll be conducting a Q&A after our panel discussion, so feel free to enter any questions throughout the program using the Q&A bar. We also encourage you to use chat to introduce yourself and engage with fellow audience members. So we'll give it just another minute. Hi, everyone. We're going to get started in just a few minutes. The webinar. Good afternoon once again, everyone, and thank you for joining us. We're going to get started in just a minute. Couple things to note you see on the screen here. This webinar is going to be recorded and all participants will be on mute throughout this program. We will conduct a Q&A at the end of this session, so please feel free to enter questions through the Q&A option. And you can use the chat to introduce yourself as people are already, and go ahead and engage with your fellow audience members as we go throughout the program. All right, why don't we get started? Good afternoon, everyone. My name is Sarah Mackin, and I'm the Senior Program Officer at RIZE Massachusetts Foundation. I want to welcome you to today's virtual event, Supporting the Workforce That Supports the People, a review of the harm reduction workforce in Massachusetts. For anyone that's just joining us, this webinar will be recorded and all participants will be on mute throughout the program. We will be conducting a Q&A at the end of this panel discussion, and we encourage you to enter any questions you have throughout the program using the Q&A option on your toolbar. We also welcome you to introduce yourself, as many are already, and engage with your fellow chat members through the chat function. The recording of this webinar will be made available through our website and YouTube channel following this event. Before we introduce the agenda for today's webinar, I'd like to take a minute to tell you a little bit about RIZE. Launched in 2017, we are the only public-private partnership dedicated solely to funding and creating solutions to end the overdose crisis. Guided by those with lived experience and unafraid of new ideas, RIZE is building networks, designing programs, and supporting community partners who are using novel approaches to prevent overdose. Since our launch, we have invested $11 million in organizations across Massachusetts. We're made up of a constantly growing group of providers, payers, unions, advocates, and people with lived experience who are equity-minded, entrepreneurial, collaborative, and dogged in pursuit of our mission. As this crisis continues to take its devastating toll, we believe that strategic workforce investments will ensure that professionals like harm reduction workers who provide critical direct care are given the tools and resources necessary to meet the needs of their clients experiencing opioid use disorder. Harm reduction, as defined by the National Harm Reduction Coalition, is a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. At RIZE, we believe in harm reduction as a key component in the care continuum for substance use treatment, yet little is understood about the size and scope of the harm reduction workforce, and we want to change that. To tackle this gap in our collective knowledge, we partnered with Brandeis Heller School for Social Policy and Management to conduct a qualitative and quantitative review of the harm reduction workforce in Massachusetts. This review conducted interviews and surveys of both harm reduction employers and employees. Today, we are excited to share the findings with you and engage in a reflective discussion. We at RIZE know that harm reduction workforce has been underground, under-recognized, and underrepresented. We also know that they are one of the most important life-saving touchpoints for people who use drugs or anyone who is seeking treatment and recovery. That is why we have made harm reduction a priority since day one. We are excited and honored to be joined here today by several respected colleagues and contributors to the harm reduction space. First, I have the pleasure of introducing the primary investigator for this review, Dr. Karen Donelan. Dr. Donelan is an inaugural Stuart H. Altman Professor and Chair of the U.S. Policy School within the Schneider Institutes for Health Policy at the Heller School. She's a prominent survey research scientist and has designed and conducted hundreds of national and international surveys of the experiences of patients, health professionals, and healthcare systems, both internationally, nationally, and locally. We're also so excited to be joined here by senior correspondent and host at WBUR, Deb Becker, who will be moderating our panel discussion today. A celebrated journalist, Deb is a recipient of many awards recognizing her coverage of key issues in the areas of substance use disorders, mental health, and the criminal justice system. Finally, it is my pleasure to introduce our three panelists for today. We are joined here by Sarah Mackin, the director of AHOPE's Needle Exchange at the Boston Public Health Commission, which is the largest needle exchange and harm reduction program in New England. Kim Powers, founder and CEO of Access Hope, a grassroots mobile outreach harm reduction program on Cape Cod, and Izzy Rivera, the director of program management and development at the Justice Resource Institute, who has over 20 years of experience in disease prevention, testing, treatment, and education. For today's webinar, Dr. Donelan will present an overview of the findings and then more specific findings associated with three focus areas: recruitment and staffing, skills, training and careers, and retention and respect. After each section, Deb will engage our panelists in discussion centered on the responses to the findings. At the conclusion of the panel, our audience members will have an option of posting questions to the speakers via Q&A. We'll also be tweeting during this webinar and welcome you to engage with us by following @RizeMass and the hashtag HarmRedWorkforce. Thank you to our speakers for your partnership in discovering more about this important topic, as well as members of RIZE's Harm Reduction Advisory Committee, whose expertise was invaluable in shaping this review. We are so grateful for your leadership and shared sense of urgency in our fight to save lives and equip the workers on the ground with the resources they need to succeed in this fight. And thank you to all of you joining us in this conversation today. With that, I'll turn it to you, Karen.
Hi, everyone. It's really my honor to be with all of you, particularly those of you on the front lines of this work. I want to acknowledge my several colleagues who have helped in this work, Carrie Michael and Laura Michelson, who both worked on this project extensively here at the Heller School, Tracy Green, who I think is known to many of you, who has really provided just wonderful guidance here at Schneider. Tracy works within an Institute for Behavioral Health. I work in a health systems institute, and we've been delighted to take on this project together and in collaboration with RIZE, and we're grateful for the funding from RIZE. Next slide, please. So we also owe a debt of gratitude to several folks who are here in the audience or who have helped us advising us as we have put this project together over the last 6 to 8 months. I won't read through all their names, but as we did want to sort of honor their contributions here. Next slide, please. So as Sarah described to you, when RIZE just about a year ago came up up with the idea of this study, they had this sort of three-part focus on how to build capacity, which in labor terms we call, recruitment, how to support practitioners and harm reductionists in their current roles, how to provide educational opportunities for growth. We know that this is historically a really challenging time in the health workforce and the kind of frontline community social services workforce. COVID has taken a particular toll both on the behavioral health issues for almost everyone, but especially for folks who use drugs and may depend on services. But it's also been really hard for the workforce, and we know that. We know a lot of folks, worked through very difficult conditions in this pandemic and are still working hard against a tide of challenges to deliver services. So it's a hard time to talk about how we get more people into work and how we support them, but this is the moment we're in, and we think it's really critical that we pause and think about how to uplift this workforce and this work. We also know that the origins of harm reduction, are in community, and many of them date back even for decades. And there's several folks here who really have lived the history of harm reduction. In contemporary times, many larger organizations, health systems, and institutions are also thinking about how they do harm reduction and taking on those techniques. So on the beginning, we felt like it was essential to understand both community-based service delivery and then health system-based service delivery, and try to see what partnerships exist and what the relevant roles are for those two players. Next slide, please. So you're going to hear a few key themes, and I'm going to start with them, and we'll end with them too. We know that jobs in this sector are varied especially by where people work and by the communities and settings and organizations you work in. They don't always fit standard codes that our systems of measuring labor or workforce use. And so this is an evolving field with a lot of new job titles and a lot of new roles in the workforce. And we're thinking forward about how we can understand and measure these roles going forward. People with lived experience have, really are the front lines of this work. And we know that those of you with lived experience who are doing this work face unique obstacles sometimes in hiring and in employment. And so we want to talk about those issues particularly. We think both organizations and workers, as opioids and substances, other substances change and new challenges emerge, there really needs to be continuing education and skill building to deal with the consequences of substance use, and to really prepare people for the new emerging drugs and the new emerging threats to people's health and lives. Growth in wages and growth in career pathways is also essential. People can't work at the front line forever in doing the same thing, especially if the pay isn't adequate. And so we're going to be looking at current wages and thinking about how careers might be developed for folks who want to move up and take on new or different roles at the front lines of harm reduction. The final point you'll hear several times today is really about how we support the workforce. We know that there is grief and trauma and stigma and disrespect playing itself out in the lives and on the front lines. We think organizations and our society more broadly needs to figure out how we can support people so that they can live through this work and be well and not suffer additionally in their workplaces. Next slide, please. So who does harm reduction? When I said before that coding here was difficult, on the left, you'll see how SAMHSA defines work with workers. Careers of Substance are some additional roles that RIZE has put together. And in this project, we've learned a lot of new titles. With housing, threshold housing, syringe service providers, harm reduction counselors. Somebody needs to mute who is not currently muted. Navigators, housing first, a whole set of new job titles that are emerging. Next slide, please. This survey was done this summer. As Sarah mentioned, we started with BSAS's list of organizations that they fund. This is a mix of inpatient, outpatient, overdose response, syringe service provider, workforce. We asked a subset of groups to help us connect with their frontline workers through organizations. The organization list is a list that is a little more steady and representative. The frontline worker survey data that you'll see come really from about a dozen organizations, so not from all the organizations, just from a subset. But we think they have valuable lessons to teach us about the lives at the front line. Questionnaire was developed by our team. We did this mostly by email and email recruitment and online survey, but we had the help to build awareness of the survey through a number of different folks. Overall, in the summer and in a difficult summer situation, about 43% of folks we contacted provided some data. About 128 organizations gave us enough data to analyze, so we'll present on those, and 74 workers. We know that there's some trust building to do. Many people answered some questions, but not all the questions, especially questions about identifying folks. So we have some missing data, but we're going to show you what we have. Next slide, please. So what types of organizations? As I said, it's really a wide range: community-based services, group living environments, recovery environments, ambulatory offices, mobile outreach, street outreach, acute hospitals, shelters, police and fire, educators, schools, corrections, and a mix of other grassroots organizations. So we heard from a wide range of you. Next slide, please. These organizations also serve a lot. They're differently sized in terms of how many clients or patients their organization provided with harm reduction services in the month, prior to people's response to the survey. So big chunk of them serve fewer than 100 people a month, but we have also 13% who say more than 500 a month. So you can see a wide range of service provision. Next slide, please. And those of you who do this work seem to form partnerships in communities quite widely. So even, we see things across really a continuum of care, from community health to residential treatment to acute services to EMS, job training and placement, low threshold housing, pharmacy, schools again. So really, people are doing this work in a lot of different places. Next slide, please. So in the next segment, we'll talk about recruitment and staffing, but we'll stop now that we've given you that overview of who's involved and what we're doing, and take it from there, Deb.
All right. Well, Karen, thank you. Thank you so much for this snapshot of what's going on. I really think the timing of today's event is something, right? We've got Boston Mayor Michelle Wu making an announcement this morning on what's happening at Mass and Cass, where, as you know, a lot of harm reduction work is going on. There's a lot of debate about harm reduction. Many of you probably just came back from the major harm reduction conference. So very topical discussion that we're having today. And I think that this sort of broad overview that Karen has brought up first for this first segment has a couple of main themes here. Not a lot of support for the workforce. And, roles vary depending on the work, depending on the organization, depending on the type of work that's being done. So now we want to talk with some folks who are working in harm reduction about what this survey might mean. So I guess my first question to the three of you is, would standardizing roles be helpful? And how do you do that in an area like harm reduction, which is really sort of grassroots and organic? And that's kind of the beauty of it, right? How do you help, and what would be the best way to do that? What would be gained? What would be lost? Kim Powers, what would you say?
First, I want to say that anything I say is my opinion and the opinion of people who use drugs and my friends. So I think that we definitely need to standardize and organize harm reduction. I mean, peer recovery coaches have a certification program. Harm reduction folks don't. And there's no real job description. You can't explain what is happening when you go into work as a harm reduction specialist. And so for me, I just to give a little bit of background of what it's like, when this all kind of exploded, when fentanyl came into the picture around 2014, and we kept gaining people in harm reduction. Different SSPs opened up. At the beginning, there were just 5 needle exchanges. So it was a really small group of people that were doing this work. And the overdose deaths are just astronomical. I mean, 2,500 people in the state of Massachusetts. Most of the people are known by harm reduction specialists. So, I mean, for me, I have a notebook that I keep, a journal, and it has 186 names in it. 186. And those are people I worked with and people that I care about. People, I have a picture of the person and I write a little quote and I go in and write other things so I don't forget the name, because you often work in this work to protect yourself with the grief. You forget who some of these people are, and that's really difficult. So I think that standardization in harm reduction probably sounds like a terrifying thing, because there's a lot of rules that are really hard to follow when you're working with somebody who's in their highest place of chaos, who's in the stigmatized, they're usually not talking to their family. So for the work to be organized, I think that we definitely need a certification program. We need more education. We need people to know what they're getting into. And then as the work grows and as you keep, adding things to it, really supporting people that have been in harm reduction for a long time. I mean, for me, the people that I call when I'm having problems or something happens are people, my friends in harm reduction, but I don't want to call them because they're going through the same trauma. So they're having all the same things I'm having. So a lot of this stuff is internalized and you keep it to yourself. To have people coming into this field and really with little experience, or they're younger, or they really don't know what's going on, it's dangerous, because you're going out, you're giving people Narcan, you're talking to people, and then you form a relationship. You see them many, many times, and then you'll see them on a Thursday at 4:00, and you find out Friday they died. I mean, I can just say with the AIDS epidemic, which was horrible, we knew people were going to die. Most people were diagnosed, and then they went through what was going on, and then we could say goodbye. You can't say goodbye to these folks. It's really one of those things where it's a shock, and it's really, really hard to deal with. So I really think that the state needs to come up with a program that is education first. People need to know what they're going to be dealing with, what they're going to be doing, because harm reduction specialists, we're counselors, we're outreach workers, we're data analysts. We're the first person that most of these folks see, and we form the relationships that are healthy. So we definitely need to come together with some sort of a educational thing and a certification program.
Izzy, how would you answer that question?
Good morning. Actually, good afternoon, everyone. I definitely agree with Kim. There's definitely a lot that can be done. I'm 100% convinced that standardizing harm reduction is key to keeping people alive. Definitely, keeping some of the core component of the harm reduction philosophy in terms of understanding that it's complex and a multifaceted approach. Definitely ensuring the human dignity of individuals, both living in recovery and people using, and focusing on sort of like the harm versus trying to change people's behavior, I think is critical to harm reduction work. I think many people that come into to this work want to change people's behavior immediately and not recognizing that this takes time, right? And so that's a key component of that. Emphasizing different interventions, I think, is important, so that one intervention doesn't fit everyone. I definitely do believe that having a toolbox of residential services, having some type of, nutrition, transportation, housing assistance, standardizing those components, I think is critical. So it's not just about handing a syringe, but really having a comprehensive tool of resources that people have access to. Definitely looking at prioritizing the goals in terms of like, why are they here? What needs to be met? I know myself, I've come very far in how I did things in terms of how I do things. And we're working always improving that ability to prioritize the person's goal that is in front of you. And I think sometimes that can be very difficult depending on who's doing that, right? And I think making sure that people are always true to that. And then trying to involve people in the process. Those philosophies, I think, are critical to standardizing harm reduction. I think the challenge about standardizing it is, I think it's perhaps some of the either local issues that might arise or state issues that might arise. So what I might be able to do in Metro West may not be the same that that can be done in Boston, for example, because it has to be needs local approval or perhaps funding limitations. So I think that's perhaps is one of the most difficult pieces. I think being open to people who are in recovery, open to people with lived experience, sort of defining what that is. Is it, someone who's actually been there, done that, and now in recovery, or is it family members or people who have really have been touched by the loss of people that that use drugs unintentionally, right? And so I think that's really key, at least in my own work and how I work with our team and how our team works with everyone else, is sort of being open-minded to who can actually work in this field, given the barriers that we have in retaining and hiring individuals that can do this work.
Okay, I want to go to Sarah quickly. Sarah, what would you say about standardization and challenges that you see right now?
Yeah, I think I'm going to play a little bit of devil's advocate here. So I think that what we're talking about is investment in capacity building and sort of creating a baseline for knowledge and making sure that folks are on the same page from everything from like how PrEP is, sort of like implemented, to vein care, wound care, to like what harm reduction practices look like in outreach. I think that that's incredibly important, especially now, as sort of a movement that has been founded and driven by people who use drugs and who have lived experience and who are living their experience. Now we sort of see a lot of folks coming to the movement who maybe don't have that and who are looking to help. And that's a positive thing, but they may not be coming it with the same baseline knowledge or approach to philosophy that the folks who sort of started this movement are continuing to keep this movement going. I think that the discussion around professionalization is very dangerous. I think that you can make some parallels to social work, right? In many ways, professionalization of social work in the 1900s was really practical. It was positive. It led to a group, from a group of sort of, people working in silos to a cohesive network of folks with standards of practice, education. It led to better pay, more resources, more acceptance of the work in medicine and public health. But this came with a lot of bad things, right? So social work became infiltrated or sort of inculcated with Western medicine ideals. These institutions, which, are rife with white supremacy and other issues, have started to kind of change have changed the way that social work is practiced. Things are, had the reimbursable model is also something that's very difficult, and it's very difficult to apply that to harm reduction. I think that the origins of our movement are strongly rooted in activism, anti-establishment, anti-racism, and civil disobedience. When you're institutionalized and professionalized, which also means that you have to register and pay for the privilege of being a harm reductionist, those things can be very difficult to continue. And I think that they're really important to our work. I think what's more important is that we continue to push, rather than for certification and professionalization, we continue to push these institutions to recognize the value of lived experience and to monetize that, right? So it's very difficult for me to, hire people who are, like either identify as drug users, and I myself identify as a drug user. I think that's a very important part of like my bio that isn't always sort of included in when somebody introduces me. So I'm a person that uses drugs. I'm also a person in recovery from chaotic use. So I think that I've had a lot of privilege to be in the position that I am, but I'm trying to bring people up who have taught me everything that I know, who have lived experience, who've lived on mass and CAS. It's very difficult to do that in the institution that I work in. So education requirements, driving record requirements, all of these things lead to sort of like diluting the movement and not allowing us to stay to keep fidelity with where we came from. So I think that we have to be very careful when we're having this conversation about professionalization versus standardization. I think there should be a standard of care for people with drug users. I think that professionalization will be the death of our movement, to be honest.
Well, we are going to move on to recruitment and staffing, and Karen's going to give us some results from the survey. So I think we want to talk about this further after we look at some of those numbers, because you bring up really interesting points, and there's obviously a division here, right? We need professionalization if we're going to boost salaries and we're going to recruit and retain people. On the other hand, how do we strike this balance and make sure that we don't professionalize our way away from what we're supposed to be doing to begin with, right? So I want to hear a little bit more from, because we only have 10 minutes in each segment, a little bit more from Karen on this, on what her survey found about recruitment, and then let's get back into some of this conversation and go forward. Okay, does that sound good? A thumbs up? Yeah, thumbs up. Okay, great. And I want to remind just everyone who's listening that we will go to a general Q&A after we present the 3 segments of the survey. So Karen, why don't you tell us what's next and what you found out about recruitment and staffing?
Great. Next slide, please. So one of the things I think that came up consistently, which you could hear actually in the responses of folks today, is that what harm reduction is, what harm reduction services consist of, who does harm reduction, all of these things. This is, even though the concept of harm reduction has been around for a long time, the last decade has been a time of sort of tremendous change and growth, I think. And so we actually wanted to ask both the organizations and the workers, sort of what services are you providing that you call harm reduction, and who's doing them? Is your organization doing them at all? And we asked this whether the person responding did it, whether other people did it too. I've combined those for now, so you can see kind of what organizations are doing. Are they doing this thing sort of at all? So the big 3 that it seemed like almost everyone we surveyed was doing in some way were overdose prevention services, some sort of case or care management support services, and then slightly smaller group, but still a number of people we surveyed are doing treatment. Next slide, please. The next set of services, maybe won't surprise people because of the environment, we're in now, but low threshold housing and shelter access is done by a number of these organizations, post-overdose outreach, drug checking, testing for infectious disease. So those are sort of, in a few cases, right, more sort of clinical lab oriented services, but also just this growing activity within helping people into housing. Next slide, please. So smaller on the list in the organizations responding to this survey were distribution of safer smoking, people doing any kind of overdose prevention, including supervised consumption sites, which we didn't expect to measure much activity in, but we got a little bit. We were a little surprised by the relatively low number of organizations that said they were doing needle exchange or non-prescription syringe distribution. But we know that the environment in our state is such that there's multiple ways to do, syringe service provision. And as we've heard, we also heard that in some communities, this is more difficult than others. And we know in some care settings from our interviews that some care settings can't do it. But and then we had a number of respondents who didn't answer this. And so this is who we know does it in this context. Next slide, please. We asked about some general work categories and the approximate wage for new hires in the organizations we surveyed. And there was a wide range, but we're giving you sort of the median here. So an entry-level harm reduction outreach worker with a college degree, $22 an hour. A harm reduction outreach worker with 5 or more years of lived or work experience, but not necessarily a degree, similar rate. Clinical social worker with years of harm reduction experience, $32 an hour. A nurse with 5 years of overdose prevention experience, $38 an hour. What we can tell you is that we heard in a lot of our interviews that people felt that lived experience was undervalued. And I think this is at least one indicator that sort of an entry-level worker with a college degree, but not necessarily with lived experience is being hired at a similar rate. This is a low hourly wage in terms of nursing, especially in today's market. And a clinical social worker who has a license and a master's degree, you know, is actually closer to the nursing level than might normally be true in some other work settings around the state. So why don't we go to the next slide, please? We asked people, so Sarah's comments were interesting to me because I think she knew this was coming, and I think, and I knew this was coming. So we asked these organizations sort of if they had the funds to hire additional staffing now, which of the following would be their highest priority? And they could write in something too. But so these aren't, 16% is not a huge number, but clinical social workers, clinicians, behavioral health counselors, peer recovery coaches actually came in higher in this mix of places than did harm reduction outreach workers. And even though a lot of people talk about difficulty hiring, we did hear in our interviews kind of a drumbeat of I can get more outreach workers if I need them. That's not true in every region. That's not true in every community where we talk to people. But there is, at least in the responses to this survey, looking for some licensed providers in addition to the outreach folks. Next slide, please. So we asked about the most important problems organizations faced in recruiting, retaining. The biggest thing was a lack of qualified candidates applying, obviously poor compensation, not enough funding to hire the workers people need. The stress of job or the burnout of the job was lower than I would have expected in this mix. And then there's a whole array of other factors depending on where people are located. Next slide, please. So that's our next segment, and I'm eager to hear people's responses. Thanks. Deb, you're on mute.
Okay, thank you. Thank you, Karen. I wanted to get a little bit more context from Karen's research before we went on to some of the things that were brought up after the broader overview. And so, Sarah, I want to ask you this first, because, when you hear about some of the things that Karen found in her survey, sort of a lack of qualified applicants, poor compensation, burnout, and things like that, and you don't professionalize people, how do you balance it so you address some of those issues that are facing the harm reduction workforce?
Yeah, I mean, I think, let me just start by saying that this was a pretty large undertaking, sort of putting out this survey, getting people to answer surveys. Like, it's a pain to get me to answer any kind of survey. So I know that there's a lot of work that went into this. I think it's really important to think about the institutions and agencies that are answering these questions, right? And I think that that's telling in and of itself. So if you have 33% of respondents saying that they give out needles, which in many ways is sort of like the basement of harm reduction, is meeting people's daily needs so they don't get HIV, so they don't have wound issues, vein issues. That's sort of like the entry level harm reduction. It makes me wonder like what some of these respondents or who these respondents were. And so like, who would you hire? That question is answered differently from medical institutions, housing agencies, homeless services agencies, which like traditionally have not really embraced harm reduction. And so I think that like, when we're identifying what harm reduction is and who is a harm reductionist, you can practice harm reduction and sort of like cleave to harm reduction philosophies. But if you are doing sort of like the basics, which is like facilitating access to supplies, like I'm not sure you're a harm reduction agency. I think if you asked just needle exchanges or harm reduction programs that have been operating in the state, those responses would look a little bit different. Like I know that for me, like of course there's a lot of medical need, there's a lot of behavioral health need. We're located in Boston. We have really strong, relationships with Boston Medical Center, Healthcare for the Homeless, other agencies that we're able to kind of like leverage our relationships to get people these the services that they need, because we provide an array of drug user health services. But ultimately, first and foremost, like my main priority is getting more people with lived experience working on the front lines. When you say lack of qualified candidates, I mean, does that mean that like people aren't qualified to do harm reduction? Or is it that the institutions have raised the bar so high that you can't hire people who would be wonderful harm reductionists and who are incredibly well qualified, more qualified than I am even, but can't hire them because they don't have a GED or a high school diploma or something like that. So I do think that it's important to, while I respect and I think that this this study has been really telling and helpful, I think it's important to understand like who's been answering these questions. That I'm going to pass it on to Kim and Izzy because I don't want to keep going.
Okay, well, Kim, I do want to ask you a little bit about what Sarah said, because you had said there definitely needs to be more professionalization, possibly certification of workers. And so if you look at the numbers that Karen gave us and said, look, there are issues here. We're having a hard time, right? We're having a hard time finding the staff we need. And Sarah's concerns as well about sort of changing the philosophy of harm reduction. What do you say to those things?
So first I want to say that professionalism isn't really what I meant. What I meant was education for people coming in, not knowing anything about HIV, HCV, wound care. I'm really not injection drug users to be, doing safe injection and teaching people how to do that. So I think that it's really, like Sarah said, it's really hard to hire people. You have to have a license, you have to have a GED, all that stuff. But then when you go for your interview, you have to open up your whole self. You have to tell them about your lived experience. You're more qualified about that. And then you become the person in the bigger ASOs, the bigger agencies where you're the person that people go to, the person with experience. And I also identify as a drug user and I'm a person with lived and living experience. And we're the person that's the go-to, and we legitimize the agency. We give them the data that they need, and they get the money from DPH and all that kind of stuff from the work that we do. So I think that for me with Access Hope, what I've done is we have a team of 4 people, and they're located all over the Cape, and they do the harm reduction work I do, but they're people who use drugs. They're people who are using drugs right now. And I think that that's so important because I pay them with stipends. There's no any kind of a application process where they're going to look at your query. I was scared to death when they were going to look at my query. I just thought there's no way that I'm going to get a job like that. So doing that the way that we do it is just critically important. And I think what's hard for harm reduction specialists too, was really hard for me, is the rules and the no's and the barriers that you have to put up with or that you have to do. So you can only go so far with helping people. So what I do and what I've always done is, we meet people where they use instead of meeting people where they're at. So we go to where people are using, and we do drug testing, and we do injection education. We do all that goes along with harm reduction, but then we also monitor the person. It's supervision, it's monitoring. We stay until the person is okay and they don't die. So the only way that this is going to work, and we're going to lower the numbers that are in the state, which is like 10,000 plus in the last 5 years, which is horrifying. And people with lived experience, it hits us really hard because healthcare and the things that go on with, our civil rights, with stigma, being stigmatized and being marginalized, et cetera. We feel that at the jobs we're at. There's a separation in the bigger programs where people that are making all the decisions and are doing all the stuff for the program don't have that lived experience, and they don't ask us what we need. So what we need is what drug users tell us. So what they tell us is we're usually the only person that they have a positive experience with. So people end up, coming to us for all this stuff. We form a relationship with them where we really care about them. And that's what drug users mean, because all of the discussions that we have, all the surveys we can have, bottom line is we meet the drug user. We don't question what's going on with them, and we give them every single service that they need. And also that's going to bring a whole group of people that aren't going to go with traditional treatment. They're not going to go to a needle exchange and tell people what they're doing. Also, harm reduction specialists with lived experience. I got to tell you, like when I've worked at the bigger ASOs, going into work immediately, there was stigma with the people that were working there with, people that didn't understand what I was doing and people that thought I was going too far. I was always pushing the envelope. I was always going too far. So I think that giving people more room to be able to do what real harm reduction is, like when back in the day, I worked with, we gave out syringes when it was illegal, and we didn't care because the main thing was not to get HIV. It was drug users helping drug users to stay alive. That's where the whole movement with harm reduction started. So I think moving back to a lot of the stuff that the history of harm reduction and the things we have to do, I think that moving forward with the way that they're hiring people, there's more restrictions, there's more things that we have to do, and we have to pull back with that. I don't have restrictions with the folks that I use. There's none of that stuff where you have to have a resume. You know how hard it is for somebody who's coming in with lived experience to have a resume, their Corey, a driver's license, and also to be able to talk to people that are in management and tell them the heartbreaking stuff, the chaos that you go through, your own trauma. So as far as like hiring people and recruitment, we have to be honest with folks that are coming in. And when I was talking before too, I was talking about BSES and DPH funded programs. Like that's not what I do. I'm never going to have those barriers. And I think that's the only way that we're going to keep people alive. So as far as recruitment, we have to recruit people who are using drugs, and we have to pay them in a way where we're not going to take away their benefits. We're not going to take away food stamps. We're not going to do that because we want to lift people up. Empowering drug users is what we need to do, period. And if we don't do that, people are going to continue to die. I mean, the bigger institutions, we've blanketed the state with Narcan and with all the stuff that we're doing, and people are trying. But if you're working in a needle exchange and you do everything, you do wound care, injection education, give people syringes, make sure that they're doing, trying to do 1-for-1, which people can't do. Narcan, all that stuff, they walk out the door, you say you can't use here. They walk out the door, and I've had that happen where the police come back or somebody comes back an hour later and says, this person's dead, because we want people to use behind dumpsters and in dirty bathrooms. And that's where people use alone. That's also a thing where it's stigmatized, it's illegal. We criminalize people with lived experience, and we make it so it's extremely difficult for us to be honest, us to open up. And for me, I have to be 100% honest to work with people who are using drugs. I'm not going to pull back. I'm not going to make them feel worse. It's identifying these are people that are my friends. So I don't know how we're going to change that as far as the recruitment with agencies who have barriers. They have rules, they have things that they can't do. And what I'm doing right now, I think that a lot more agencies need to do that. We need to supervise. We need to be able to do the work we need to do. I think a lot of people that do harm reduction, especially like in Boston, the big urban areas, they have to lie. They have to not tell what they're doing because they'll get in trouble and they get fired. Or they'll get, people will say that they're rogue and they're not giving, 100% of what they're doing. And we have to hold back because the truth is, if you really meet someone where they use, then you really make a difference in their life. So that's my opinion on all that. So I know that hiring people is a real process. It's a really hard thing to do. And I think we need to pull back. We need to hire people with the manager or somebody's thing which says, you have lived experience, we're going to pay you.
Right. So Izzy, it seems like there's widespread agreement here, right? People with lived experience are hugely beneficial to this workforce, and we need to figure out a way, to keep them, to retain them. So I wonder, what would you say? I mean, how can the process improve to make sure that people with lived experience are welcomed into this workforce?
Yeah, I mean, as Kim and Sarah pointed out, I think the challenge we have, I mean, I definitely agree with a lot Kim and Sarah had brought up, that harm reduction has its specific skill sets and have a specific role in the community, which is to reduce death, ensure that people stay alive and are able to use safely and minimize harm. And I think that that's the key component of harm reduction services, right? I think the other pieces are also true, that people need to get into Hep C treatment and people need testing available to them, right? And I think that that all is going to look very different in different regions. And I think that's the challenge that we have. So Sarah pointed out, for example, that folks can actually go in to the program, and their focus is really, it's around minimizing harm, providing syringes and some in a lot of the harm reduction work, and that she has a really like robust CBOs and organizations where all these other services can be met. That is not true in all regions, right? And I think that that's the challenge that we have, that while some of us are doing harm reduction, we also have to meet the needs of people trying to get into Hep C treatment, trying to get them into STI treatment, trying to get them into housing. And so some of our harm reductions staff are playing the role of many different hats. And so the idea of social workers that points out on the survey is pretty much what Sarah had pointed out. Who are those people that are being interviewed, right? I mean, if you're asking us, because we are in Metro West, we will like clinical social workers. We would love case managers and behavioral health clinicians, because there isn't anything out there for people who use drugs or who are in recovery that is at least culturally relevant and sensitive to the needs of the people that are in that spectrum. And right. And so I think that will definitely vary from place to place. Definitely agree that, you know, folks should have and the ability to get a job regardless of their level of education. So obviously in our case, that doesn't, you know, that's something that we are able to do within our current practice, right? But I think if you work at a health center and you're trying to do a harm reduction service, the having a GED or having a college degree is critical to them. It's the way the system has been built. Is that a disservice? Absolutely is a disservice. So how do you hire people who really are relevant to the work, that can do the work and still have other employees who can meet the needs of people who are in crisis, or even the staff? For example, like we have a full-time behavioral health clinician on site that works with the staff, that works with clients, addresses issues of crisis, helps people, you know, self-care issues that come up, trauma that may come up, the compounding trauma that comes up over and over again of doing this work, but as people are dealing with overdoses. I mean, all of it is true.
Mm-hmm. And I wonder, what do you think in terms of, you know, what roles would be the highest priority to fill right now? I wonder, you know, what really would it be? Social workers, clinicians who could prescribe? I mean, what would be the role here, and what do clients need? What needs are not being met, and what roles need to be filled to kind of address that issue?
I'm sorry, I think we're asking the wrong question, to be honest. So I don't think it's about the roles. I think it's about like what's being provided and what needs to be provided. And the reality is that, of course, like I can't, as a harm reductionist, as an outreach worker, can't provide the same kinds of services or care that like an NP can, or even a social worker or behavioral health specialist, but we are doing a lot of this work already. And so I think that like when you categorize these things into roles and positions, we start to get into kind of like a really kind of strained debate about like who belongs doing this work. And I think that like what we're thinking about is like capacity building, right? So what are some of the areas in which like we need to develop capacity within people who are on the front lines providing this work? Because the reality is people like Kim are going out to folks in encampments where no one else is reaching them. And she is assuming these roles, doing housing referrals, taking people to medical appointments, doing wound care. That's what we are all doing on the front line. So I don't think it's about who do we need to hire additionally into these organizations to provide these services. It's where can we establish needs for capacity building, and also establish needs for sort of linkages to referral networks with agencies that are like-minded that can provide some of these services that maybe are a little bit beyond our expertise. So I just want to be very careful about, like, should we be hiring NPs? Should we be hiring social workers in harm reduction agencies or programs? I think you get into some difficult situations there.
Well, I think what I want to ask is, what do you need to do? So you're not doing 15 activities. Maybe you're only doing 3 because you can put some 12 away and give them to someone else. Who's going to do those other 12? It may not be a social worker. It may be someone else. It may be a wound care specialist who can handle some of those things that may be more time consuming. I wonder what you think from your work might be most helpful to reach folks and reduce the workload. So one harm reduction person who, there's a huge umbrella there, as you mentioned, right, Sarah, isn't doing it all or expected to do it all. What is most helpful?
Oh, we don't want to do it all. It's
Right.
exhausting. So, but the reality is like what we need is we need more organizations that have the ability to work with people who use drugs and who are providing these services on a daily basis and have the expertise. Like, there are amazing NPs, nurses, doctors that we work with, the healthcare for the homeless. We're like, I wouldn't ever send anyone to any other place other than some of these NPs and doctors, because I love them and I trust them. And I see the way that they work with our people, and I know their dedication to the harm reduction philosophy. It isn't that, like, what do we need to integrate within harm reduction agencies? And that may be the most appropriate thing to do in some areas, like rural, models of harm reduction, where like they're going out to people in their homes or encampments. And like, maybe you do bring a doctor with you, maybe you do bring a nurse, a social worker. But for us in Boston, at least in an urban environment, what we need are more like-minded professionals who have the background and capacity to practice harm reduction and to work with our people in a low threshold environment. So I think it's other institutions that need to be challenged in the way that they deliver services. And I also think that, like, within professionalized roles like social worker,
Right.
nurses, doctors, like, there has to be some education and sort of standards around delivering care to people with used drugs, a sort of drug user bill of rights, a drug user, like,
Right.
sort of like bill of standard of care, if you would. So we don't want to do it all. We want to be the triage. We want to do everything that we can possibly do in that moment, but ultimately the goal is to connect people with who we trust that can take them to the next level and do the next thing for them.
Can I add to that? I want to add to that. That's really important. So when they say, what do we need? There's enough social workers and healthcare workers that I can go to. And I form relationships with specific people. I can get Suboxone on the same day. I can get somebody at the methadone clinic fast. I can go with somebody and do the wound care. So you develop these relationships, and I don't go past what my capacity is, what I know I can do. I'm not going to try to be a social worker or a counselor with somebody, or a grief counselor specifically. I'm going to pass that person on. So I have folks that I've formed relationships with that I know that I trust, because there are agencies that I'm not going to send people to. There are places that I just don't trust, places that I wouldn't go to, places that are going to stigmatize, or they have rules or whatever. So, all these rules that can't be met. So I think what we need more people that are going to do the frontline work, the boots on the ground, be able to have the freedom to go out to do the hard work that we need to do. And I think there's enough social workers and there's enough healthcare workers, specifically on the Cape, except for the lower Cape. I'm not really talking about the lower Cape. There aren't the services that they need down there, because, from Provincetown to the hospital is an hour. So I think that whole area needs harm reduction specialists. They're going to go in the camps. They're going to make people feel comfortable. And we're going to approach people again where they use, having people come into an agency, having people have to come into a brick and mortar is extremely difficult in the rural area. Getting a ride, there's all kinds of barriers that go on. So, with harm reduction specialists, like Sarah was saying, more education with the social workers and the healthcare workers. I mean, people on the Cape say it's all white. It's not all white. 37% of the kids in the schools are people of color. And what we're doing is we're not reaching those folks, because they don't, again, go into traditional treatment, go into them. There's a lot of people that just don't know we have what we have, including like the smoking. Like, they have a big, huge thing in the state about giving out smoking supplies, giving out bulbs and pipes and all that stuff. And isn't it like, it just makes no sense to me, because if somebody's going to smoke instead of inject, it's definitely harm reduction. It makes it so that HIV kind of gets out of the picture. Like, HIV is blood to blood. That's a syringe. That's where we have to get to people. So giving harm reduction specialists the room to do, or the freedom to do the work that they need to do, is what we need in the workforce. Period. And that's my opinion, obviously, but we just don't have enough folks. Like, for me, I have to find a way to get funding for stipends, which is not something that's traditional. So putting that down on a grant and figuring out how I can get $12,000 to get through 3 months is wicked hard. It's something that really had to do because BSAS and DPH are not going to fund that because it's not something that they feel like is important, which it is important. Again, hiring people that you're going to pay in a different way that don't have what agencies want. They don't have the background because when you start asking people, you're doing their query, they want a license, GED, all that kind of stuff, you lose a huge number of people that are going to do the work and are going to save lives. So if we don't have that, we're failing. We're failing the people that are using drugs. We're failing people. And it's obvious by the numbers of death. They put the numbers out right in December. There's 3 months of the medical examiner not even getting to people. The number in Massachusetts has raised well over 2,500. That is something that people that are going out in the street, people that are going in the camp, people that have the freedom to do what they need to do. We have to do what drug users need to do. Drug users are what this whole thing's about. People use drugs, or most people won't have a job. The social workers, the healthcare centers wouldn't even have a job. So focusing on people who use drugs, we have to do the work we have to do, period. So what I think we need is more people with boots on the ground, that we're paying with stipends, that we're not making do the traditional thing, that we're going to have. Those are the people that are saving lives. Period. They're rescuing each other. They're saving lives. They have the tools they need because we give them to them. And again, the only way someone doesn't die is if they're supervised and monitored. So what I do too is when I do overdose education and give people Narcan, I always do supervised education as well. I tell a family their kid's not getting into detox for 7, 8 days. They're still going to use. So we have to bring that in where the parent is going to, or the loved one is going to watch the person and make sure they don't die, because people die when they're alone. Period. And the only way that we're going to get to people again, and I'm going to keep saying this, and I'm going to keep yelling about it over and over and over, the safe consumption sites, they're going to be in Boston. They're not going to be in the rural areas. They're going to have the pilot programs there, and they have a 10-year thing. It's going to be way harder for us to get that. So like going into people's homes, going where they're using, and making sure that they get through the 20 minutes. And after they use, they don't die, but we're not there all the time. So there's a lot of stuff that we do on the phone. It's not a 9-to-5 job. It's a whole, we get asked to do stuff all the time. So I have people that'll call and I'll just listen when they're using. That's what we need to do. So hiring more people that can do that, hiring people that'll answer the phones, that are going to be able to be there when people use. That's what we need, especially on the Cape. And I'm obviously talking about the rural areas.
All right, we're going to have to just move on because we're going to get to the next section of Karen's research, and I'm going to let her present what else she found out in terms of this survey, and perhaps address Sarah's question about the respondents as well. Karen?
Yeah, so what we're going to do, we're going to break a little bit from the agenda, and I'm just going to go through the rest of the data and therefore try to give everybody a little more chance. There's amazing stuff going on in the chat as you're all contributing to. Couple of just quick points of clarification, both to things in the chat and from the speakers. The respondents here are program directors. So when we got the lists from BSAS, we got a list of programs with executive, clinical, and sort of frontline program directors, and we had the most success reaching program directors. And that's a range, people with a range of titles and skills, but they are, somebody had said, gee, are these all the executives? And the answer to that is no. I think that there's no question that the mix of people, that the list we use was the BSAS list, in part because what harm reduction is not, at this point, when we started to look for how we would approach all of these workers in a way that would help provide policy data that was somewhat representative, it's really tough to find a list. And our list, frankly, had a lot more people in grassroots organizations, but those folks, I think, are too busy or had trust issues or whatever. So, not a perfect response rate, not a perfect representation, I think. And we know those limitations. This is sort of the first time we've tried this. So one of the reasons to start with the folks we started with was to say, we know that this is a mix of organizations. They're not all grassroots traditional harm reduction, but we also know that big systems are moving into this space. And we heard again and again in our qualitative interviews that even if physicians, nurses, hospital folks are not traditional harm reductionists, that learning the principles of harm reduction is really essential for everybody, because we would like people who use drugs to be able to go anywhere in our systems, anywhere in community services, and have people understand these principles, and find their way to folks who are more expert for sure. But we know, and all you need to do is read the local papers, that the principles of harm reduction are not widely understood, and there's a lot of pushback out there. So we're trying to find who has this philosophy, what does it mean, what kind of activity is coming. Not everybody has been doing this work historically for as long as you folks all have. And yet we have a lot of young, I have a lot of young students here who are really interested in this work. Some who've lived with this with drug use, and some who haven't. And I think as we start to think about this very large, sort of set of issues and services that we need to get out there, part of what we wanted to understand is who's even thinking about this and who's doing anything. So you all started to get into what are the resources and skills people need. Could we go to the next slide, please? One of the things that I thought was most telling, we asked the frontline staff, are there other harm reduction jobs that offer higher pay or different work conditions that you're interested in? And the biggest response here was people aren't sure. And what that usually says to me is that, they don't know what other roles they may qualify for. They don't necessarily know what education. So I think part of developing, sort of a pathway in this work is trying to help people understand what might be next, what might be a road to higher pay, higher education, or training or certification as we try to develop. And I don't think everybody needs to be a professional to answer Sarah's question. I do think that when we code jobs, when we think about classifying jobs, there's plenty of jobs that are not listed as professional jobs with all the stuff that goes with that term. I think there's a lot of good work out there, and there's a lot of good skills people can learn. So next slide, please. When we asked frontline staff what barriers might be to overcome to advance in their career, we had a lot of the kinds of things we just heard from Kim, content in training, got to learn about substances, have to learn about phlebotomy, but also I need a degree and the money to pay for it. I need to learn how to apply for grants or funding to get more supplies. And we heard about those financial barriers again and again. How can I both earn money, work, and go to school? How is that possible? We also heard this theme, which, we heard from all of you about, who's valuing degrees over lived experience? Are some of the job opportunities out there only offering jobs to people with more formal education and the classism that's associated with that? And then a need to sort of say employers need to recognize work experience as just as valuable as higher education. The other theme we heard especially from the folks, with lived experience, was that for some of them, recovery and continuing in their recovery is a very high priority, and that they needed to know how they could maintain that in other roles, other jobs, other work settings. Next slide, please. So key training themes from the organizational perspective. Quality harm reduction requires timely continuing ed and training, need for high quality training and people who really know how to do this work. But it needs to be tailored and flexible to different kinds of workers and different kinds of settings. We kept hearing that harm reductionists encountered difficulty in access to both informal education and skill building and formal education. And finally, and I saw this note in the chat as well, what educational, professional, philanthropic organizations can step in to help sponsor some of these trainings and certifications, because not all small employers can mount them or fund them or manage them on their own. So how do we aggregate that training? Next slide, please. So the final theme is sort of worker retention and respect. Next slide. So what were the main things we heard from the frontline workers about what they needed for support? And I think one of the most interesting themes to me was how often people didn't talk about themselves and what they themselves needed. What they mentioned first were additional resources they needed to serve people. So they talked about housing. There was a big theme around diversity, which, you know, we heard Kim just mention. Do we have services for people with limited English proficiency? Do we have people of color providing services to people of color? How do we overcome barriers for people of color? Are staff trained? You know, is there lived experience of both drug use and you know, sort of a whole array of cultural needs, disability, gender identity, racial and ethnic lived experience? We heard Izzy talk about a centralized, updated set of resources that was easily accessible to everybody. That's another place I think where outside agencies can be really helpful. Lower barriers to test strips, reagents, syringes, higher wages, over and over and over, higher wages, more training, and then policy change that would help everybody in safe supply, lower barrier to methadone, supervised consumption, cash stipends to help people do Narcan distribution. Next slide. Organizations told us that many of them offer a wide array of paid time, benefits, training, workforce training, and yet we still see these unmet needs, very low on sort of the union membership. I want to highlight how few places say they are providing support groups or programs for workers who are coping with grief, or who provide higher pay for off-shift differential work or give time off for folks who need support. Next slide, please. We asked both a whole set of questions, and I don't have time to go through these, but I really want to look at the bottom of this slide where we were asking for ratings of whether you rated your organization excellent or very good on a number of aspects of work. And this is where we say, you know, support in trauma and grief, not rated very highly, career development, not rated highly, certain benefits, health insurance, dental, not rated highly, the opportunity to flex away if you're burned out or you need a change, not rated highly, salary or wages, not rated highly. Next slide, please. So these are the themes I started with, and I'm going to not read through this again, but you know, what we see is wide needs for training. We've heard that, I think, from Kim, you know, more effort at compensation, at financial support, whether just for work or for work and education. And I want to end again on this need, I think, to recognize that organizations need to do better to support people with grief and trauma, and would just note that the behavioral health providers, the social workers, some of those professionals, if they were available to organizations, are not just there for client service, they are there to also do support and supervision and support groups for workers. And so not every organization may be able to have those, but that is a way that we might be able as a society to provide some service to organizations that need to support their workers. And I'm going to end there. I'm amazed at what I'm hearing from everybody and what I'm reading, and just really happy to be here and to listen to everybody for the rest of the time. Thanks.
All right. Thanks, Karen. I'm going to ask folks if they'd like, they can post questions, and we will try to get to them. But I just want to pick on something that Karen had just talked about, especially about staff retention, training, more training, compensation. There were some folks mentioning in the chat that, you know, continuing education resources could be really helpful to people to make them feel that they're not blindsided by new issues that might come up and have to learn it on their own. And so I guess I wonder, you know, so it's clearly established, and I think all of you agree, the workforce needs more. And Kim, I think you had a little bit of an opportunity to talk about what you feel that you need, but I wonder if Izzy and Sarah might be able to talk about some of the things that you think you need and how your workforce can be practically supported to be able to improve some of the things that Karen found in her survey. Izzy, I'd like to go to you first.
Yeah, I mean, I want to first sort of say something that I think, it's sometimes difficult for us to acknowledge. If we think about the HIV pandemic back in the 80s and the 90s, about our model of care at the time was really addressing a very critical moment, right? Where people needed support, they needed a buddy system, they needed a time where we were able to help navigate a complex time around stigma, around issues of people not belonging. And I think that is also true and has historically been true for people who use drugs. And I think that one of the things that I had found to be interested around this pandemic of drug use is that we really didn't acknowledge drug use until white people started becoming impacted, right? And I want to bring that to surface because I think that talks a little bit of the privilege issues that we have had historically in society that people who are brown and black didn't have. And the pandemic was really ignored during the time when overdoses were happening, people were dying, right? And so now, we have had a history of where harm reduction has become the foundation of supporting people who use drugs. And I'm happy that we can take that opportunity and ensure that safety is also there for people of color that historically has not been there. One thing that I've learned in my 30 plus years of doing this work is that and I speaking for myself as someone who was didn't have a level of education, didn't have a degree, implemented these programs. It was difficult for me to shift what we were doing traditionally for many, many, many years the same way to think about what can be done differently and think outside the box. And I think that this is where we are right now. I think we are in an area where the needs of the communities are different. I hear over and over from our SSP staff, from our clients needing housing, needing nutrition, needing transportation, needing behavioral health services, issues of prices that come up on a regular basis. And those are daunting to think about, to address, right? And I think that doesn't happen overnight. It takes really critical thinking and thinking about like, how do we make this happen? And I think, Sarah pointed this out very, very well too, that, that there is a very important piece that sometimes gets missed, that I sometimes have overlooked, even as a program director, that the people who can convince, who can work with people, who can really sort of like understand and empathize and sympathize and be compassionate are true harm reductionist folks, right? That have lived it, been there, understand it, grasp it. I understand that. And, and when I think about that and what we need to do, how do we make these two things happen, right? That is true, and yet we also have to do this other stuff. How do we make it happen? How do we ensure that the clients are getting everything they want and we're not just focused on one area of what they need? And I think that is a hard conversation. Like when I started hiring nurses and medical assistants and started working with behavioral health clinician and harm reductionists, like we're always engaging about like, what is it like to provide these services? What offended you, or how could have I said something differently to make sure that, right? And I think that takes constant work, the same amount of work that we have to take when we think about issues of racism, when we think about issues of class, stigma. I mean, if we don't have those conversations, we don't talk about it, we're not gonna improve the quality of life for people that use drugs.
Can I
I
add
mean,
something?
yeah.
Let me add some. I don't mean to interrupt, but I want to add some. Izzy, thank you so much. I want to thank RIZE for doing this. I think that they push the envelope and they kind of do that. I know that we didn't get a lot of people for the survey. I had a real hard time doing that. But I want to say that also harm reduction specialists are asked to do a lot. They want us to draw blood. So somebody that's a drug user, I couldn't do it. They asked me to use that tool to draw blood when syringe was my thing. So I think that they also have to look at what they want us to do. It's way too much. It's things that we're not qualified for. But I went to a phlebotomy class for a day. And then my experience with drug use is what they really counted on, because I knew how to use a syringe. I know how to draw blood. But going to the state and telling them that I wasn't drawing blood because if I did, I was going to use drugs was really difficult. It was a really hard thing to do, and agencies won't let you do that. So that's what I wanted to add to. We need to stop that.
And I agree. And I think that's actually just to kind of go on what you had just said, Kim. I think that's what we need to do, right? Is to help DPH and BSS understand that it takes different levels of people to be able to get the work done. So like, for example, when I think about funding levels, I mean, if you fund me to do a harm reduction program or an SSP program for $200,000, I mean, the answer is what the hell are you asking me to do? Are you asking me to do integrate STI testing, harm reduction work, syringe services, O&D with $250,000? That's not going to happen, right? So how do we then demonstrate to DPH is here's what we need for you to understand that we definitely need harm reduction to do this work. We need people with lived experience, and we need phlebotomists. We need other teams of people that can help work with us to make sure that people are getting their needs met. I agree. I struggled. I remember pushing back with our own programs because we were told that the harm reduction staff had to do testing, had to do patient navigation, had to be social workers, had to be, O&D folks. And then we decided, no, we're going to shift that model. We're going to try to do X, Y, and Z. And I still go back and forth with that, right? Because they're asking us to do something, and yet we have to figure out what the model is to get there.
Mm-hmm. So I guess this is such a great discussion, and I'm so sorry that we're going to have to cut it short in a little bit because we're going to run out of time. But I guess I want you to each think about, final messages that you give to the workforce, and make them short, please. And what would you say? This is really what we need. I mean, Sarah, you said some amazing things about, knowing who to trust, because there are only some organizations you can trust, even though they're doing harm reduction, right? And so how do you set standards, have standardized care, have it be a system where somebody doesn't have to guess who they can go to for help because they are operating in the same philosophy? I mean, what do you do to improve the workforce and make sure you get what you need in all of this? And I'd like each of you to answer this and say, this is my challenge. This is what I need. Sarah?
Yeah, so let me just first say for our program specifically, what I have found has really been helpful, or what I'm trying to move towards now is, we have an amazing team of people, all of whom have brought something different to the work, to the team. RIZE has been an organization that has allowed us to kind of push the envelope a little bit. And for example, drug checking was something that we were able to do, and then sort of set a precedent and say to our funders, who've been very, very supportive our entire sort of 30 years of existence at the state. The state has they fund us very well. They're very supportive of, things. When I say, hey, listen, I think we need to make some adjustments in staffing. think we need to have maybe a drug checking coordinator specialist, or we, maybe need to have someone who's bumped up to a coordinator role for X position, or benefits specialist. There are things that within harm reduction that people do really well that we need to recognize as maybe specialists, right? Who can both develop capacity inwardly in a program, with new staff, or to kind of help offset different talents and other things, with other folks that they work with on a team. I think that there is a lot to recognize within harm reduction in terms of the tasks that we do every day and the things that we bring to the table that are unique, and to build on that and to have capacity building. And I think that when we've said to our funders, listen, like we need capacity building around this, or we need to recognize this is a really important part of harm reduction, they've heard that, right? So one, I think we need to recognize that harm reduction needs to be a low threshold entry. So I don't think you need to be a specialist to begin doing harm reduction. I do think there needs to be standards of care or standards of competencies for folks that are working with people that use drugs. And I think that is for everyone, who whether you have lived experience or not, there's a baseline for that. I think that there has to be, for the wider harm reduction workforce, an agreement that is informed by harm reductionists who are currently doing the work, who have lived experience, who are living in experience, which is something also that the state is doing, starting to kind of turn to folks who have lived experience and who are living their experience and say, what is it that we need to do to build harm reduction in a right way? So I just want to point that out, that I think that BSAS and DPH are doing a great job with that and have come a long way. And there are folks within that institution that have pushed for that, to recognize that there is expertise, right? It's not necessarily about the professionalism, but lived experience is expertise that can be codified in such a way to develop capacity in other institutions. I think there just needs to be cultural competency, sort of basics for doctors, for nurses, for, folks who are social workers, housing specialists. Absolutely. I mean, people ask me, what is harm reduction? I'm like, baseline, don't be a jerk, to people that use drugs. It's very simple, be forward with love, be kind, be compassionate, be open-minded. But these are things that can be trained and can be people you can expose to people in a way that makes sense to them.
Yeah. And I guess one thing, when Kim and Izzy, when you guys get a chance to answer, I also want to think, I've been to Mass and Cass a bunch of times. Sarah, I've talked with you a bunch of times about your work. I just also think this issue of supporting people who are doing really difficult work is also something that I'd like you to address. How do you support folks doing some really tough work? And as Karen mentioned, there's a lot of trauma and a lot of grief that you guys have to deal with all the time. That's tough work.
Yeah.
Kim, what do you say?
So, real quick, what I want to say is BSAS, they came up with a harm reduction advisory council. And so they are trying to work towards that. So if I came off harsh about DPH and BSAS, I know I often do, because I bring up the past with that kind of stuff. So I think that with harm reduction specialists also need to do the policy work. We need to be able to talk to the people that are working, that are making the laws, and people that in our agencies that are saying, this is what we're going to do. I think that harm reduction specialists should be in positions of making those kinds of decisions, seeing what's going on, telling people what we need to do with funding, etc. So that's a really important piece. I think if we don't get our voice, and if we're not in the conversations that have to do with the law and policy making and getting together and do stuff, I know that, like I said, BSAS has come up with that advisory council, and what they want us to do is really, become those people. So I think that we, again, I'm going to say, people who use drugs, people with lived experience have to, whatever that bring to the table thing. We invented the table, the table was us, we did that. But because we don't have specific educations, et cetera, we just don't go. There's a ceiling to our work. I could only do it. There was a ceiling. So you do that thing. And then the agencies or the places also want to keep you there, going to higher management. You're not exactly that person that's out on the street. And we legitimize the agencies. We bring them the data. We do all the stuff we need to do.
Okay. Just briefly, Izzy.
I think for sure, there's definitely we have a lot of recurrential trauma and stress factors that I think both as employees, as programs managers, undergo on a regular basis. I think definitely having clinical supervision is important. I know that we offer it twice a month now at our team. And still people have the ability to do one-on-one using the employee assisting program. I think is important. We have an amazing employee assisting program where people can access it if they needed to. One, because I think there are things that happen that sometimes managers and program directors shouldn't need to have that conversation with, because sometimes people feel threatened by whatever it is that's going on with them. Allowing, for people to be able to relapse and going into treatment and coming back to work. I think those are true and also very challenging for program managers and for the team. We go through that quite often in our program where something like that happens. We bring them back and then something happens again. And then so how do you manage that? I think is really important and stay true to that. But then understanding the impact that it has on the team and then on the clients. I think, you know, this work is difficult. Let's be honest about it. Like when we're dealing with people who are in whatever spectrum it is, right? Whether that's contemplating or in maintenance or somewhere in between, it is hard because, you know, some people who are in recovery would say otherwise. That may be a trigger to me. And for people who may be using, feel more embracing of like being around other people, right? And so I think that it is a very difficult work and balance to have on a constant basis, but I do think that is doable. I think it just means a lot of conversations and a lot of meetings to ensure that we stay true to the mission of working with people across the spectrum, and staying open, you know, to constructive feedback and criticism from both parties. You know, I think right now and even before, we've always had really great people in those positions. So I think I've been blessed with having really nice folks who have come to us. I have lost others because I have not provided the attention that people deserved at times, right? And I acknowledge that and own that. And I think that is truth with any of us. I think that we're doing so much that sometimes we forget what is really important, and we have to be reminded. I really always tell my team, like, tell me what's going on. I want to know. I really want to do the best for everyone involved. And I think that if I keep saying that to myself and I keep listening and trying to make, you know, small incremental changes to support that, that we will get there. I just think it's really, really difficult work when you're trying to be everything to everyone in in an area where not a lot exists.
Right. All right, I unfortunately it's 1:30. And so we're gonna have to end our conversation, but I really do think that the three of you have been great. Someone in the chat said maybe we need part 2. I think they might be right. There is an awful lot to talk about here, and to get into some of the specifics. So I want to just say thank you to RIZE for doing this work. Thank you, Karen, for doing this research, and thanks to all three of you for sharing your firsthand experience. Thank you.